welcome to Plastic Surgery Consults with the McRae Twins. I am Matthew McRae, and this is my twin brother, Mark.
Yes, hi. Okay, so let's get into it.
Yeah, so today we are just taking a closer look at sensory recovery after breast reduction surgery. So we have some basic stats that we'll start our episode with, and then we'll take a deeper dive onto the different anatomic factors, patient factors, and surgical factors that influence recovery of sensation after breast reduction surgery. So I guess to start off, just to state that once again, breast reduction is a surgery with an incredibly high rate of satisfaction. And even with sensory changes, should they occur, and I think we can talk on the actual numbers on the transient nature of a lot of these sensory changes, but even if there's a long-term change, generally, you're still dealing with a very, very happy patient population that are very grateful that they did this surgery. Maybe you could comment a bit more on the stats, Mark.
Yeah, and I think then this nipple areolar sensation is also applicable to our breast lift patients. So breast lifts may also have some sensory changes, although the incidence is not as high as they are in the breast reduction patients. Breast reductions, we generally do breast lifts within that surgery. So in terms of just baseline numbers, when you're talking about pros and cons with the surgeon in consultation, if you are a surgeon or a patient, if we look at the data from our literature in plastic surgery, we have about 22% of patients will experience some degree of sensation changes. I think that's just the numbers from the Plastics and Reconstructive Surgery Systematic Review and Meta-Analysis that was done in 2025 by Arbiuso et al. So that is, generally speaking, most patients from that number will recover baseline sensation by 6 to 12 months. Approximately 8 to 10% of patients report a persistent subjective decrease in nipple areolar sensation. In terms of objective testing that's been done in the Annals of Plastic Surgery, and we'll have this in our show notes, that there are some alterations that can be tested based on these monofilament tests. And Matt, maybe you could describe that really quickly, just in terms of how that's tested.
So monofilament test is basically small little thin threads that are pushed on your skin, and based on the diameter of that thread, it can be pressed harder or less hard. So the perception of the skin. So as the thread becomes smaller and smaller, eventually you won't be able to feel it. But these monofilament tests have been tested thoroughly for sensory changes throughout the body.
Okay, great. Yeah. So generally speaking, in that study in the Annals of Plastic Surgery, that significant decrease that does occur for many patients at 0 to 3 months returns to baseline by 6 to 12 months. And then in terms of the sensibility of the nipple areolar complex, we sometimes call that the NAC, it decreases at the first follow-up and returns to normal by 1 year based on those studies. And then the one that was interesting about is just the thermal sensation, the heat and cold detection, how that does lag. So it will often remain impaired by 6 months or 3 to 6 months, whereas tactile sensation does recover and normalize. So
yeah, I think you're pointing to an important point that there's sensation can mean very different things. There's different types of sensation, right? So tactile sensation is just the sense of being able to feel something that's touching you. Thermal sensation is hot or cold. There's also the sense of your body in space. That's another area where sensory feedback is important. And then, sensation, erotic sensation also, I guess that would be something important for the nipple areolar complex, which I think is very closely tied to tactile.
Yeah, absolutely. So I think in all those reasons, even though these studies are really focusing on tactile sensation, I think that's something that can be much more easily measured, right? As opposed to some of the complex interplay between like the sympathetic and parasympathetic nervous system and all those kind of erectile tissue and all those different things that happen in the nipple areolar complex, which haven't necessarily been studied as extensively. What does the general kind of nerve science tell us in terms of timeline for all of that maybe potentially normalizing or not? Do you have any info on that?
Yeah, I think the thing for sensory changes after surgery, you can expect basically, these studies really show us, and I think that's true to our personal experience as well, you can expect some sensory changes over the first couple of months. And that's why for us, part of our recovery is wearing a bra that does not push into the breasts in ways that could potentially damage the skin, because we know that there is this at least transient sensory change that generally occurs. But you can expect, and these numbers back it up when we look at these studies, you can expect that really to return basically to baseline, basically back to normal for you pretty soon. Now, if at a year you still don't have kind of your baseline sensation, there still is hope actually. Really, for most areas of the body, sensory changes continue to evolve at up to 2 years. I think at the 2-year mark, you're probably you're kind of going to be where you are.
I think that's really helpful information for patients and for surgeons and for counseling about this area. And it's nice to have these papers to kind of back up that information that kind of fits well within our general understanding of nerve recovery. Why don't we switch into a little more on the anatomy? Again, just a slightly deeper dive in terms of that.
So we know that the sensation to I guess most importantly would be the nipple areolar complex itself. But the breasts in general, there is some variability in anatomy. But if you're to look at your spine, so there are different areas of the spine. There's a cervical spine, thoracic spine, and a lumbar spine. Those vertebrae, the nerves that provide sensation to the chest come from the thoracic spine, so the middle section of the spine, and really centers around that T4 level, so thoracic vertebrae number 4. But there is certainly some involvement between the second thoracic vertebrae all the way down to the 6th thoracic vertebrae to the chest itself. And so there's a lot of variability within human beings. It's not true for everyone, but that I think is the general, what anatomic studies show us, that those are the main sensory areas that are provided for the breast. And Mark, maybe you could just tell us the actual course of those nerves as they travel from the spine?
Let's do that. Yeah, at the risk of boring some people, but really interesting to the anatomists in the audience. So there are really anterior cutaneous branches and lateral cutaneous branches. So that means that basically when these nerves come around underneath the ribs, there's branches that come up from beside the sternum, and those are the anterior cutaneous branches. And then there's branches that come up from the lateral. We call it the anterior axillary line at the lateral side of the chest. In the case of the sensory contribution to the breast, the lateral branches tend to be a little bit more dominant in most patients. And it's really the 2nd through 6th intercostal nerves, we call them. The 4th one, intercostal nerve, being the predominant contributor to the nipple areolar complex. And that's the one we are generally most interested in terms of what we're discussing there. In terms of the path of that 4th intercostal nerve based on cadaver studies, it tends to run along the pectoralis major muscle fascia and then kind of exit more about 93% of the time directly behind the nipple areolar complex and kind of project straight out up to the nipple areolar complex. The anterior cutaneous branches, though, tend to course much more commonly in the subdermal, so just below the skin area. And so that really does impact things when we're talking about how we are actually performing these breast lifts and breast reduction surgeries. From the 2nd to 6th intercostal nerves, that's important in terms of us considering our surgical approach and dissection, whether it be breast lifting or breast reduction surgery. And that can go into a little bit more about those studies that look at the pedicle. Now, pedicle is is an interesting term. Matt, maybe you could provide us with an understanding of what a pedicle is and how that relates to breast lifting and breast reduction surgery. And then we can maybe mention really briefly what a couple of those studies, which aren't the best studies, but tell us and why that makes sense.
I think there are some important things. So now we kind of have an idea as a group. We have the idea of what the anatomy is in terms of where the sensation comes from. And that has a very direct impact on our surgical technique. So there are surgical factors that can increase or decrease the possibility of sensory change with the surgery. So the pedicle itself refers to the blood supply. That's a critically important point for plastic surgeons. We're always concerned with blood supply to the tissue that we're looking to change and the tissue we're looking to move around. So the blood supply to the breast, we know that there are blood supplies really from all directions, superiorly, medially, inferiorly, and laterally. But we do need to make sure that whichever tissue that we want to preserve our nipple areolar complex on, we need to make sure we preserve that specific blood supply, because part of the surgery is ensuring that the nipple and areola remain alive and viable after the surgery. So the pedicle itself is really where that blood comes from to provide the remaining breast tissue to keep it all sensate, and viable.
Okay, and so I think just to give a little more clarification, because I think even based on how you said it there, sometimes patients will ask me, so you mean you take the nipple areolar off and put it back in a better position? So no, we don't. So what that means is we do make incisions in the skin level to free the nipple areola from the level of the skin, but below that, the breast tissue itself, the parenchyma, it stays attached to the chest wall. And based on what direction it's attached to, if it's attached to the chest wall based on the superior tissue, that's a superior pedicle. If it's based on the medial tissue, it's the medial pedicle. If it's the inferior tissue, it's an inferior pedicle. Anyway, so those are the terms. Generally speaking, when I was training, most surgeons initially were tending to use more of the inferior pedicle, and it kind of evolved within my training years to more the superior-medial pedicle. And there's a lot of benefits that we find in that in terms of the aesthetic results, but that can also have a slight impact in terms of the predominant tissue where that's being removed. And maybe you could tell me, so the predominant tissue being removed, if you're doing a superior-medial pedicle, well, that seems to be kind of opportune for the aesthetic when we're trying to lift the breast. But maybe you could just mention that quickly. Yeah.
Exactly right. So really the tissue that most people are interested in is the superior tissue. So everyone's looking for more volume of the breast superiorly. And that's because a youthful breast tends to be an elevated breast, a breast that is higher on the chest wall. And with time, with kids, with weight changes, with gravity, the breast progressively is pulled down the chest wall. So when you're looking to make a breast more youthful, it's really about bringing that tissue up. So in the setting of a breast reduction, that tissue that is superior and medial is really the tissue that is precious. And that's the tissue that you really want to preserve a good looking, aesthetically pleasing breast. And the remaining tissue that is removed tends to be the tissue that is inferior. So that is a bit of a shift and a change over the past 30 years. As you mentioned, Mark, I mean, when you were training, it was almost entirely inferior pedicle tissue that people would preserve, but then you have a lower sitting breast on the chest. And now I think really the standard for most plastic surgeons is a superior medial pedicle, which really gives you that aesthetic improvement, really to turn the clock back on where the breast is located on the chest wall.
Yeah. So, and I think that, people doing inferior pedicles aren't wrong. They're very tried and true techniques as well. And if the surgeon you're going to, that is their comfort zone, they're going to give you the results that they're showing you in their before and afters, et cetera. That's how they do it. Then yeah, that could work very well. I think that in our practice, we tend to really have moved much more towards that for the reasons that you described. And there are times, of course, more like an oncologic surgery and stuff where there's resections of tissues where we still will use inferior pedicles. It's just a tool in the toolkit, but ultimately I think it helps.
And that ties in a little bit to surgical technique and its influence on sensation. So there are some papers that show some surgical factors, and it does tie into the patient factors as well. So, the question is one technique better than the other? Is one pedicle more tried and true in terms of sensory recovery? And, I think the most studies that have looked at this have looked at it in the inferior pedicle, and that's really because that's the technique that was used and was really the standard of care for so many years. And then comparing that to other pedicles. Now, unfortunately, most of these studies really, it's nice that there is a result so you can kind of report on it, but I don't think you can really place a lot of trust in the results based on the methodology. So the way the studies were conducted, I don't think were done very, very well. But it does seem to point to that the pedicle technique itself can influence sensation. Perhaps, if you do an inferior pedicle based on some of these studies show a very low incidence of any sensory change after inferior pedicle. But then there are other studies that show that, there's actually profound sensory changes after inferior pedicle technique. So I don't think really you can judge a lot, but maybe Mark, we talk about just in terms of how you might fashion that pedicle, and that might be more influential on how the sensation changes.
I think it's interesting. And I think that, just talking about the anatomy that we just did about how that lateral cutaneous branches tend to be dominant. And if they're kind of traveling along the pectoralis muscle fascia and then go directly up to the nipple areolar complex, well, if you're doing that inferior pedicle and really preserving the tissue that's immediately below the nipple areolar complex, then maybe you have a little bit better chance of preserving that. In the superior-medial techniques that again are much more gain much more traction, there is the option to really thin out that pedicle much more, because we know the blood supply tends to run in that subdermal plexus a little more superficially. And so we're able to make that pedicle much thinner and reduce the breast more. But I think that if our goals are to maintain that sensation, that particularly that lateral cutaneous branch, then you really want to maintain the connections to the pectoralis fascia so that nerve has a good chance of reaching in that 93% of the time. It'll still come up to that nipple areolar complex. The anterior cutaneous branches, though, tend to be subdermal much sooner. And so those tend to, if you're going to dissect around that pedicle as it goes to the medial edge towards the sternal side, if you're cutting down through that tissue beyond the dermis itself, you have a much more chance of impacting those. So if you're strictly a superior pedicle, for example, just keeping the tissues connected above, be mindful that you're going to probably be sacrificing some of those anterior cutaneous branches, which will impact the sensation of your patient.
I think that impact, as we discussed in these papers, is generally transient, right? So even if those nerves are disrupted, they will find their new targets with time, and sensation generally is restored. But there are some patients where that does not occur. And I think to kind of round out our discussion of kind of surgical factors, so I think you're right, that's a big point, is how much you remove. And there are studies that really show that resection volume and sensory changes are very closely tied. So if you are looking for a large reduction, really, it seems like the number in the studies really show that anything over 500 grams, this seems to be kind of a waypoint between, less than 500 or more than 500. If it's less than 500, most often the sensory changes are much more, reduced. Whereas the sensory changes, which you start getting with these large reductions, over 500 grams per breast, you do start having at least a transient loss of sensation or a decrease of sensation. Because when you think about it, you're removing so much of the breast, and then the chance of those little microscopic nerve branches to be incorporated in that resection increases.
Yeah, it's great. And that paper you're citing there is that number 5 on our list. It's that defining predictors. That's a 2026 paper, which is great. And again, it did show that tactile sensation in a month greatly impacted if you're greater than 500 grams, but still long-term impairment tends to be pretty low. So that's great.
Those are just from the cervical technique factors, really is, your choice of pedicle, how much you thin out that tissue under the nipple areolar complex. And really that points a little bit to how far you have to move it. So if you have someone whose breasts are down by their belly button and you want to move it up, well up their chest, well, that's a long way to go. And you do have to thin out that, the tissue under the areola to be able to move it that far. So again, these are different surgical factors. Now, there are also patient factors, and patient factors, one would be age. So we know that nerves tend to heal quicker in people who are younger. So in terms of the length of time for recovery will be different based on age as you get, with each decade of life. And then things like diabetes or other factors that can affect your nerve recovery.
Yeah, ultimately that one paper that we were sort of citing did show higher BMI was the strongest predictor of persistent loss of sensation across 3 to 6 months.
So BMI is, so BMI is just a ratio of your height to weight. So if you're obese or higher, then
you'll have a larger chance. So if you're obese, and then there's again been some mixed results in terms of, there's actually some mixed results in terms of age, body mass index, and tobacco in some studies, but I think those are generally kind of safe ones to consider. Okay, great. So I think that's a really great information. I think ultimately all these studies do generally comment still on the relatively common occurrence of sensation changes, but the fact that patient satisfaction remains consistently high. And so that relief of, particularly in the breast reduction patient, the macromastia or large breast symptoms and aesthetic appearance changes are such that satisfaction is very, very high, even in the presence of sensation changes. And again, we get that in the area of breast lifts as well, I think, lesser extent. But yeah, do you have any other closing comments?
Yeah, basically, it's worth it. It's worth it, right? And the one other thing I think we haven't mentioned is just that, so often it can be an issue of decreased sensation, certainly temporarily, but there can also be the issue of increased sensation. And there are certain patients, I think, that are more prone to that. For example, patients with fibromyalgia, very common condition. Those sensory changes in the fibromyalgia patient tend to be that of hypersensitivity. And sometimes for them, it's a matter of desensitizing the breast after surgery. Things like manual massage. You need that sensory input to decrease the sensory, the central sensory input coming from the breast. So there's a chance also of having hypersensitivity of the breasts as well after surgery.
Yeah, and I was surprised, a little bit surprised that just in reviewing the literature for this episode, how that isn't commented on as often. I think it is commented on, but I don't think it's necessarily studied or tested for because the incidence is probably lower than loss. But I've certainly seen in our patients having some hypersensitivity, or one side being hypersensitive, one side losing some sensitivity. But again, I think that counseling, that there's things you can do in terms of if you do have any pain syndromes like fibromyalgia, things like, pain control after surgery, massage.
Yeah, the biggest thing really being just patient expectation, right? Just to be able to tell them, listen, you have fibromyalgia. This is something that you're more prone to. Also, I think it's part of that patient-surgeon discussion is, listen, the most important thing to me in the world is that I preserve sensation. Well, then we can change the technique around a little bit to improve the chances of that, right? By preserving the column of tissue under the areola. Now that may mean that you may not be able to get as much tissue off, right? So there's a bit of a give and take in terms of what your goals are. Is it maximal removal of breast volume and make it as small as possible? Is it that you want to move things as far as you can up the chest wall? Or, there are different things that you can kind of, as a patient, discuss with your surgeon about what your goals are, and that may actually impact their surgical plan for you.
Yes, that's great. So I think this will really give you a nice segue into our next episode, where we're going to discuss the impact. I guess we're going to discuss breast recovery after breast reduction and breast lift surgery. And also I think we're going to, in the next or future episodes, discuss the impact on breastfeeding. So there's a big, complex neurologic interplay within that kind of complex process of lactation. And that's an important consideration, particularly for patients within childbearing years or considering surgery during childbearing years. So we'll bring that up on a future episode, and we have all that data ready to go.
Yeah, it was definitely, you could dive deeper into all these topics much further. And I think hopefully over the course of years, we will kind of revisit this actual topic of sensory changes, because I'm sure there are nuances that we haven't touched on. And there's a lot available to discuss, and this could be a 4-hour thing. So we'll keep it pretty broad strokes for now. And hopefully this gives some really good information for people considering breast reduction or mastopexy breast lift surgery.